Hello, everybody. Welcome back to the Incubator Podcast live from the CHNC Symposium in Denver, Colorado. We're very excited to have on with us this afternoon members of the focus group on neonatal transport, Dr. Rebecca Martinez-Hannon and Dr. Vedanta Dariya. Rebecca, Vedanta, thank you so much for being on the podcast.
Thank you. We're happy to be here.
Yeah. You gave a presentation looking at variations in neonatal transport procedures and practices. We were talking with Rebecca off air about this. It's just like, it's so interesting. It must be so interesting to find all the ways in which people put together a transport team to try to do the same task, basically, right? But how we're all doing this from different perspective. Can you tell us a little bit about some of the things you've identified, some of the things you found in this project, and how people take on neonatal transport in a variety of ways?
Yeah. So I think one of the things that was most interesting to me and that I kind of straddled coming from training in Missouri to working in Los Angeles was the role and the uses of respiratory therapists on a lot of the transport teams. It's kind of, for the most part, in general, most teams are using a respiratory therapist. But there's some states where respiratory therapists are not given an expanded role. A scope when they go out alone without a physician. And so those states are relegated to not having a respiratory therapist with them. And that completely changes the entire structure of the team. The nurse knows how to work the ventilator. The nurse knows how to intubate the baby. Yeah, it's completely run by them. And then
that's what the nurses who
be highlighting which facilities.
Those nurses should put just that on their resume. Be like, I am a registered nurse and I can actually work the vent. I mean, that's it.
I'd be careful doing that. There's hospital administrators waiting for that to happen, potentially.
But the makeup here, the team configuration, I have this slide. RN, RT, EMT, 76%. That's one type of team. Two RNs and an EMT, 21%. And that's the other type of group. And then an RN, an APP, and an RT, 14%. Interesting. Very interesting.
Yeah, which is interesting because for most people, I mean, I have trained in that 14% category. I mean,
oh, wow.
Yeah, we always went out with a nurse, with an RT, and with a fellow usually. So it's interesting that this is not the norm. Yeah.
Isn't that funny? Things that we do, especially where we train, we think is like the way
that's how it is.
Just everywhere.
Yep, that's how God intended medicine to be delivered.
But I think transport teams are especially interesting because depending on where you work, and these all have EMS professionals, right, including in many of the teams, you may be collaborating with people outside of your unit. Can you guys talk a little bit about what that looks like?
Yeah, so I think the bottom line is, and you guys have touched upon this, and we tried to make this a lot of the focal point of our presentation, is there's variability. And I know that seems obvious, and we're stating the obvious, but there are so many different factors that weigh in when we look at that variability. What kind of transports, how acute is the patient? What kind of distances are we talking about? What kind of hospital support are we getting when we put together these teams? What availability of staff? That is a lot of times a limiting factor there. We may, in an ideal world, think or believe firmly, strongly that this needs to be the configuration of the team, but do we have those resources to be able to provide that
on standby for these level 1 transports,
especially when a lot of our units, we are, I think we can all agree upon this, that we are struggling to staff our own units with the complexity of patients that
call people is tough.
Right. And now you are trusting a hospital potentially to have the ability to staff these transport teams, because as we pointed out, for the most part, there's been a shift in where these transport teams reside. There's fewer and fewer centers that have their teams embedded within the NICU. Yeah. So these are effectively teams that are employed by the hospital. Yeah. They tend to draw from the ER, from PICU, from NICU. And then you're training everyone up to a certain level to be able to care for a patient that needs to, a 14-year-old that's had, trauma that needs to come into the ER, or a kid that has an asthma exacerbation that needs to go to the PICU. And so finding our place as neonatal intensivists and the specific needs that we have for our patients, training our staff, our transport team staff up to that level but then also ensuring that they have the ability to care for the other patients that they need to bring into the hospital system. So
what I'll say is I liked to see this data. I'm not sure it's the right move for hospitals, but it made me feel better that other people are dealing with the same pressure points that we are.
100%. And the one thing we found, we made a comment in our presentation about like, oh, but we'll alter the team structure. Like if it's a lower acuity patient, like maybe an RT only goes out if there's no IV, or a nurse can do 2 liters nasal cannula. But everyone universally agreed when we went through the data with our focus group, like point by point, we're only doing that because we're so short-staffed. No.
Would do if we could have it wouldn't be the dream team.
You got to keep it going.
There's no variability. I think what is our staffing model? I think our administrator would be like on the brink of catastrophe. That's where we want to hit that sweet spot.
Doing the best we can.
That's so interesting. Well, I also like, since we're talking about the team, this slide about when does the physician go on transport? So tell us a little bit about that.
Yeah, so I came from an institution that as a fellow, again, no RTs on the transport, in our particular group, we went often, less than 28 weeks gestation, we had to go because we were the primary airway. So I went on trips all the time. And then the institution I work at now, there's actually a transport physician that's their job. Wow. That is solely their job. So I actually do that role as well. But you're doing it for everyone. So I do transport for older children as well. But I was surprised when we put out the survey that people are like, oh, physician, never, not ever. We're like, any, and they're like, no.
Wow.
Yeah, and then when we try to examine what factors, I mean, I think we've all potentially dealt with these situations, and you have to be cognizant of duty hours for trainees.
Yeah, for sure.
You have to be very cognizant of that. I think as more and more transport teams are housed at potentially, in a geographical site that might be away from the facility, we're now trying to be very cognizant of response times.
Yeah.
And so when you're dispatching a team, do they have the ability to swing back around and pick up a fellow, to have them sent out on the transport, which is great for their learning, because just like Rebecca said, the learning that you get when you go out as a physician on transport, it is very, very interesting. We have these expectations of units that are sending patients to us, and we're like, why hasn't this been done? And why hasn't that been done? But it also helps open your eyes to the reality that is, the world outside of that resource-rich environment that is the level 4 NICU. And I think that's such a critical piece of that training for trainees. But there are so many moving parts with this equation. And I mean, I think the good thing is more centers, more academic institutions are recognizing the value of that. And there seem to be more discussions now about how do we get our fellows, our trainees more involved in transport, which I think is a really important thing.
No, it really is.
And to your point about, I guess, physicians or somebody on the team having transport-related administrative positions. So 86% of respondents said somebody had an administrative role related to transport. But interestingly, only 48% had any clinical FTE dedicated to the transport team.
That made me, and I said it during my presentation, like, this makes me actually deeply very sad.
Yeah.
I mean, I'm very fortunate to work at an institution that values what I do in the realm of transport medicine. But it makes me so sad because we talk to our colleagues and how much work and dedication they're putting into their teams as well. And to know that less than half of them are getting compensated for the time and the effort that they're putting in, it makes me really very sad.
Well, I think there's a certain standpoint, depending on how busy your transport team is, it's, dare I say, dangerous to not have dedicated clinical time to responding to the problems associated with that.
Absolutely.
But I think that's where we appreciate a forum like the CHNC and this, this podcast where, hopefully we can get this information out to people, because till we ask this question, we're all confined to what our environment looks like. And if you work with someone who has an FTE exemption, then you think, oh, maybe that's the norm.
Right.
But when you start looking further and you have the ability, and it's wonderful that we have the opportunity to present these data, it's only now that people will hopefully start having these conversations. And, speaking of some of the slides, when you think about one of the centers that we talked about, and maybe you'll touch upon this, but I'll bring it up anyway. One of those centers is doing 1,100 transports last year.
Yeah.
So that's
like it's almost like 100 transports a month.
Yeah.
So that's
Kind of.
Fast math.
close enough. Yeah.
That's terrifying.
Yeah. So, and again, I'm not saying that that center did not have that FTE exemption. Please let me be very clear about that. But I think it serves to highlight what is being done. And as we all recognize the complexity of patients that we're caring for in our level 4 NICUs, well, they're all coming from somewhere. And guess who brings them to our unit? It's the transport teams.
That's right.
And so to me, whenever we identify variability, especially in the data, the question that it poses is, what do you think is going to be what you're going to explore in that variability? Because I think that's really the cool aspect of saying, well, if everybody's doing it differently, what are the variables now that you're going to start looking at and seeing how that variability affects whatever outcome?
Yeah, I think when we had like a little roundtable discussion during our lunch yesterday, we were kind of talking about, okay, so are we trying to say there is a standard of team composition that goes out? But then you say that, what if like legally you can't actually do it? And so I think it's really tough to kind of say, you know, what we're going to do with that piece of it right now. I think we're more looking at what is everybody doing? Where does everyone need help? Where is everyone struggling? And how can we help best support you there?
Yeah.
Well, I'll just say in terms of variability for this, I'm going to advocate for everybody. I don't run our transport team, but I guess you could say I don't have an FTE exemption, but 50% of my colleagues who are running the transport teams do have an FTE dedicated. I think we could flip the percentage and you could advocate to your administrative team that you need the time to.
Yeah, and transport is something that we care deeply about. I'm going to just plug a podcast that we did a while back. It's episode 158 of the podcast, where we hosted a few members of the military who talked to us about their neonatal transports through the military, and sort of these long transports from Asia to the US and so on. So that's kind of cool. And transport is a fascinating subject, a fascinating topic. So for any trainees interested, I think it's really something that might be interested to reach out to the focus group and maybe get involved.
Absolutely.
And we were kind of shocked about what they were doing on transports, but it looks like your teams in the CHNC are doing a lot of work. So you've got this slide. Okay, therapeutic hypothermia, sure, either initiating it or continuing it. Capabilities for nitric. Teams are intubating, giving surfactant, doing needle decompressions and umbilical lines. I think almost all of the centers were doing that on transport, which I think is a
Scary stuff. I hope that happens at the facility before they head. I really hope so, because it's just, even intubation. I've had to intubate in the middle of the highway, and it's a scary proposition.
Yeah, I don't like that one bit. So what's the future for this focus group? What are your plans?
Yeah, so I mean, I think the first step was, ensuring that we had enough people to come together, to put our heads together and say, this is what we're doing. This is why we're passionate about it. This is the challenges we're facing. If I may, we'd love to have more involvement. We had almost 30 centers respond, but there's more out there.
Yeah.
And if there's people that are interested, we'd love to bring them into the fold. There's so much stuff that we discuss on our monthly focus group calls. And so the next step is, like Rebecca mentioned this a little while ago, we're trying to do this in parallel. We're going to try and address some things that we potentially can come together and put out as consensus statements, potentially, because there's not much by way of that in the literature. Neonatal transport potentially, this is a lot of times buried under pediatric transport, and there's nowhere near the numbers that adult transports have. So there just isn't a light that's shone on that. So hopefully, working on that, but then also collaborating with some of the other focus groups. We've toyed with an idea of working with the HIE group, cooling on transport, how we're doing that, how well we're doing that, what are some of the things we could be doing better, because collaboration is the name of the game, especially at the CHNC. So, yeah.
Okay, we're looking forward to hearing more from your team.
Yep. Thank you for dropping by.
Thanks.
Thank you so much.